Welcome to the Rad-On Smart Review GI Cancer series. We are really glad you could join us.
Yeah, great to be diving into this. Today, we're tackling a really crucial topic in GI radiation oncology, the evidence-based management of locally advanced esophageal cancer.
Exactly. And this session, it's really designed for everyone, whether you're just starting residency, deep in clinic, or maybe even getting ready for boards.
Right, we want to break down the key trials, the sort of clinical thinking that shapes how we actually treat these patients day to day.
Our mission here is to really pull out the most important pieces of information from these major studies, give you a clear roadmap, essentially.
Yep, a roadmap. And hopefully we'll throw in some memorable facts, maybe some analogies, things that will stick with you for clinic and exams. Think of it as, a focused tutoring session.
Okay, so let's dive right in. Picture this. A patient walks into your clinic, newly diagnosed with locally advanced esophageal cancer. The very first question, the absolute fundamental fork in the road, is what?
Is this patient a candidate for surgery? That's it.
Right. It seems simple, but that one decision really dictates everything that follows.
Absolutely everything. It sets the entire treatment strategy. Are we going for a cure with surgery as part of the plan, or is surgery off the table?
So let's explore that first path. What if surgery isn't an option? Maybe the patient has, severe heart disease, bad lungs, something that makes a big operation like an esophagectomy just too risky.
Or maybe the tumor itself is just too involved, right? Wrapped around the aorta or something you just can't safely remove. Unresectable disease.
So for those patients medically inoperable or unresectable disease, what's the path forward?
For them, the standard pathway, the goal, is definitive chemoradiation.
Meaning treatment with curative intent, but without surgery.
Exactly. We're relying entirely on the combination of chemotherapy and radiation to try and eradicate the cancer.
Okay, that's pathway 1. Now, pathway 2. The patient is medically fit. The tumor is considered resectable by the surgeons.
This is honestly the more common scenario we see, especially with adenocarcinoma being so prevalent now.
And for these folks?
For them, the standard of care involves neoadjuvant therapy.
Meaning treatment before surgery.
Right. Specifically, neoadjuvant chemoradiation.
Yeah.
Followed by the planned surgery.
And the idea there is to shrink the tumor, clean up microscopic disease.
And ultimately make the surgery more successful. Increase the chances of getting it all out with clean margins. That's the goal.
Okay, 2 distinct pathways based on that initial surgery question. Let's really dig into pathway 1. First, definitive chemoradiation for the unresectable patient.
Perfect. And when you talk about definitive CCRT for esophageal cancer, there's one trial that absolutely defines the field.
You have to know this one.
You absolutely have to know RTOG 8501, Radiation Therapy Oncology Group 8501.
This trial basically answered the question. Does adding chemotherapy to radiation actually help these unresectable patients?
It did, and in a huge way. This was published way back in 1992.
New England Journal of Medicine, a true landmark.
Before this, practice was all over the place. High-dose radiation alone. Chemo first, then radiation. Maybe some concurrent chemo. Nobody really knew for sure.
So 8501 stepped in. What did they do?
They randomized 129 patients. Now, it's important to remember these were mostly patients with squamous cell carcinoma.
Okay, primarily squamous histology. Staging.
T1 to 3, N0 to 1. So locally advanced, but not metastatic.
Got it. And the 2 arms they compared?
Arm 1 was radiation alone, and they pushed the dose 64 gray in 32 fractions.
Trying to maximize the effect of radiation by itself?
Right. That was kind of the thinking at the time for definitive treatment. Arm 2 was the experimental arm, concurrent chemoradiation, or CCRT.
Okay, chemo and radiation together. What was the radiation dose there?
A bit lower, actually. 50 gray in 25 fractions.
Why lower?
Because the chemotherapy acts as a radiosensitizer. It makes the radiation work better, so the idea was you might not need quite as high a radiation dose to get the same or better effect. Plus, managing toxicity.
Makes sense. And the chemo regimen, it wasn't just concurrent.
Correct. It was 4 cycles total. 2 cycles were given concurrently during the radiation.
Okay.
And then 2 additional cycles were given afterwards as adjuvant therapy.
Ah, so hitting it during radiation and then giving some more afterwards for good measure. What drugs?
The classic combo. Cisplatin.
Platinum agent.
And a 5-day continuous infusion of 5-FU.
Cis-5-FU. A regimen we still see.
Absolutely. Known to work well in squamous cancers and synergize with radiation.
So they set up this comparison. High-dose radiation alone versus slightly lower-dose radiation with concurrent and adjuvant Cis-5-FU. What happened?
Well, The results were so incredibly striking, so positive for the CCRT arm.
Is that they stopped the trial early?
Exactly. It became unethical to keep randomizing patients to the radiation alone arm because the benefit of CCRT was just overwhelming.
That really tells you something. So the numbers, what was the survival difference? This is the part everyone needs to remember.
This is the number to burn into your memory. 5-year overall survival in the radiation alone arm, 0%.
Zero.
0. In the concurrent chemoradiation arm, 27%.
Wow. From 0 to 27% absolute survival benefit at 5 years. That is just massive.
Unheard of, almost. The median survival also more than doubled. It went from about 9 months with radiation alone up to 14 months with CCRT.
Huge difference in outcomes.
Yeah.
What about local control? Did the CCRT actually control the tumor better in the esophagus?
It did, significantly better. At 1 year, the rate of persistent or recurrent local disease was 65% in the RT alone arm,
Okay.
but only 46% in the CCRT arm. So a definite improvement in controlling the primary tumor.
But it wasn't all good news, right? Adding chemo usually means adding toxicity.
For sure. And this regimen was tough. There was a 20% rate of grade 4 or higher toxicity in the CCRT arm.
So 1 in 5 patients had really severe, potentially life-threatening side effects.
Exactly. It highlights that while this treatment was life-saving, it required careful patient selection and really good supportive care. It wasn't easy treatment.
But the conclusion was undeniable.
Undeniable. RTOG 8501 firmly established concurrent chemoradiation specifically, 50 gray with Cis5FU as the standard of care for unresectable, locally advanced esophageal cancer.
And that nearly 30% absolute survival benefit is still one of the biggest we've ever seen from adding chemo to radiation.
In any disease site, yeah.
Okay.
It was truly practice-changing, and that basic principle holds today.
Okay, incredible trial, foundational. Now, let's switch gears back to that other path, the more common one today, the medically fit patient with resectable disease.
Right. And here, the conversation shifts entirely to neoadjuvant therapy. And the trial that really defined this approach is the CROSS trial.
CROSS, another absolutely essential trial to know.
Published in the New England Journal in 2012, this one really cemented the role of giving CCRT before surgery.
So who are the patients in CROSS?
They randomized 368 patients. These were folks with resectable disease, stage T1N1, or T2 to 3 and 0 to 1. So again, locally advanced but operable.
And histology. We said 8501 was mostly squamous. What about CROSS?
Mostly the opposite. About 75% of patients in CROSS had adenocarcinoma.
Okay, so much more representative of, say, a typical U.S. or European practice today.
Exactly. 25% had squamous cell, but the adenopredominance is key.
And what were they comparing?
Arm 1, surgery alone, just upfront esophagectomy.
The old standard for resectable disease.
Right. Arm 2, neoadjuvant CCRT, followed by surgery.
Okay. And what was the CCRT regimen in CROSS? This one is really important because we use it all the time.
We do. It's famous for being effective and well-tolerated. The radiation dose was 41.4 gray in 23 fractions.
Noticeably lower than the 50 gray in 8501.
Right. Lower dose, partly because you're planning for a big surgery afterwards. You want to minimize tissue damage that could complicate the operation.
Makes sense. And the chemo, not Cis5FU here.
No, they used a weekly regimen. Weekly carboplatin, dosed at an AUC of 2.
Okay, carbo instead of cisplatin.
And weekly paclitaxel, or Taxol, at 50 milligrams per meter squared.
The carbotaxol regimen, why weekly?
The main reason was tolerability. It tends to cause less severe side effects, especially less myelosuppression, compared to regimens like Cis5FU. The goal was to get patients through the chemoradiation in good enough shape to actually undergo the esophagectomy.
Keep them fit for surgery.
Exactly. Don't delay or prevent the curative surgery because of treatment toxicity.
So CROSS compared upfront surgery versus this well-tolerated neoadjuvant weekly carbotaxol and 41.4J followed by surgery. The results.
Profoundly positive. Just like 8501 changed the game for unresectable disease, CROSS really changed it for resectable disease.
Let's talk survival first.
Okay. Neoadjuvant CCRT nearly doubled the median overall survival. It went from 24 months with surgery alone
2 years.
to 49 months with neoadjuvant CCRT followed by surgery.
Wow, over 4 years median survival. That's a huge jump.
Massive. And the 5-year overall survival numbers reflect that too. 33% for surgery alone, boosted to 47% with the neoadjuvant approach.
Almost a 15% absolute improvement in 5-year survival. Really significant.
Very significant. But the survival benefit is likely driven by some key pathological findings.
Like getting clear margins, the R0 resection rate.
Exactly. This is critical. In the surgery alone arm, the R0 resection rate was 69%.
Okay, so about 2/3 got clear margins.
But in the neoadjuvant CCRT arm, the R0 rate was 92%.
92%, that's a massive difference.
Huge. And we know that achieving an R0 resection is one of the strongest predictors of long-term cure in esophageal cancer. If you leave microscopic disease behind at the margin, the chance of recurrence is much higher.
So the neoadjuvant therapy significantly increased the likelihood of the surgeon getting all the cancer out.
Precisely. It cleans up the field for the surgeon.
You mentioned an analogy earlier like a road crew.
Yeah, I think it helps visualize it. Imagine the esophagectomy as a marathon. With surgery alone, the road might have potholes, debris, microscopic tumor deposits.
Okay.
The neoadjuvant CCRT is like sending in that expert road crew beforehand. They clear the debris, fill the potholes, shrink the main obstacles. It makes the surgeon's job running that marathon much smoother and way more likely to end successfully with clear margins.
That's a great way to think about it. Makes the surgery itself more effective. What about completely eradicating the tumor before surgery? Pathologic complete response or PCR?
Another key metric. Overall, in the CROSS trial, 29% of patients who got neoadjuvant CCRT had a PCR.
Meaning no viable cancer cells left in the surgical specimen.
Correct. Nearly a third of patients had their tumor seemingly wiped out by the preoperative treatment.
But you mentioned earlier histology matters here too.
It matters a lot. That 29% overall PCR rate breaks down very differently. For adenocarcinomas, the PCR rate was 23%.
Okay, about 1 in 4.
But for squamous cell carcinomas, a remarkable 49% PCR rate.
49%. Nearly half of the squamous cell patients had a complete response pathologically.
Exactly.
Yeah.
Which really highlights how much more radiosensitive squamous cell cancers tend to be compared to adenocarcinomas, at least with this regimen.
We need a way to remember that number.
How about squamous smashes PCR?
Squamous smashes PCR. I like it. Almost 50%.
Nails it down.
Yeah.
Shows that dramatic difference.
So taking it all together, the survival benefit, the huge improvement in R0 rates, the significant PCR rates, especially in squamous.
And the fact that the carbotaxol regimen was quite well tolerated.
Cryo-RAS really set the standard.
Absolutely. Neoadjuvant chemoradiation with 41.4 gray and weekly carbotaxol became the standard of care for resectable, locally advanced esophageal and GE junction cancers. It improved surgical outcomes, led to better downstaging, and most importantly, helped patients live longer.
Okay, fantastic summaries of 2 absolutely crucial trials. Let's transition now to some clinical pearls. Quick, high-yield takeaways.
Perfect. Let's boil it down.
Pearl number 1. Take it away.
Okay, Pearl 1. For unresectable esophageal cancer, concurrent chemoradiation is king. Our TOG-85-01 proved it.
That nearly 30% absolute survival benefit at 5 years 0 versus 27%, can't beat that.
It's the standard for a reason. Huge win.
All right, pearl number 2.
Pearl 2. For resectable esophageal cancer, neoadjuvant chemoradiation dramatically improves the chance of an R0 resection.
From 69 to 92% in cross.
And that R0 resection is critical for long-term survival. Getting clear margins is paramount for cure. Neoadjuvant therapy helps achieve that.
Excellent. And pearl 3.
Pearl 3. Histology matters for response, especially with neoadjuvant therapy.
Squamous smashes PCR.
Exactly. 49% PCR for squamous versus 23% for adeno and cross shows that difference in radiosensitivity. It's important for counseling patients and thinking about prognosis.
Great pearls. So 8501 for unresectable, square and S for resectable. Seems straightforward, but is it always that simple now?
Well, medicine is never that simple.
Yeah.
Right? Cross is a solid standard, but the field keeps moving. People are always asking, can we do even better?
And new data comes out that challenges things.
Precisely. Recent trials are definitely making us think, and in some cases, potentially shifting practice again, especially for adenocarcinoma.
Okay, like what? What's challenging cross?
The big one generating a lot of discussion is the ESOPEC trial.
ESOPEC, what did that compare?
It took patients with resectable adenocarcinoma, so the main group from CROSS, and randomized them to either the CROSS regimen.
Okay, our standard neoadjuvant CCRT.
Or perioperative chemotherapy using the FLOT regimen.
FLOT, that's 5FU, leucovorin, oxaliplatin, taxotere. A more intensive chemo regimen given both before and after surgery, but without radiation.
Exactly. So CROSS chemo-RT versus FLOT chemo alone. head-to-head for resectable adenocarcinoma.
And the results?
The results favored flaunted. Median overall survival was significantly better with flat 66 months versus 37 months for the cross arm.
66 versus 37 months. That's a huge difference again.
It is. And it strongly suggests that for fit patients with adenocarcinoma, maybe this more intensive perioperative chemotherapy approach is superior to the cross chemoradiation protocol.
So is FLOT the new standard for adenocarcinoma then?
It's definitely a preferred standard for many, especially in Europe where the trial was run. But there's a really important caveat, a confounder we have to mention.
Okay, what's the catch?
The ESOPEC trial was designed before adjuvant immunotherapy became standard after neoadjuvant therapy for patients without a PCR.
You mean like nivolumab, based on the Checkmate 577 trial?
Exactly. Checkmate 577 showed a big benefit for adjuvant nivolumab after neoadjuvant CCRT and surgery if there wasn't a PCR. Patients in the cross arm of ESOPEC did not get adjuvant immunotherapy.
So the comparison isn't quite fair to the cross-S approach as we practice it today.
It makes it complex. How much better would the cross arm have done in ESOPEC if those patients had received adjuvant nivo? We don't know for sure. It makes a direct comparison really tricky.
Gotcha. So Phili looks better, but the lack of adjuvant immunotherapy in the comparison arm is a major sticking point, a nuanced decision.
Very nuanced. Requires discussion with the patient about the pros and cons, the data, and the uncertainties.
Okay. What about other chemo regimens with radiation? Did anyone try swapping out the cis-5FU from 8501 or the carbotaxol from CROSS?
Yeah, people have tried. For example, the French PRODIGE5 trial looked at using FOL-FOX concurrently with radiation instead of cis-5FU.
FOL-FOX, folinic acid, 5FU, oxaliplatin, another common GI chemo regimen. How did that go?
It turned out to be more toxic, actually, particularly more neuropathy, which can be a really bothersome long-term side effect from the oxaliplatin.
Okay, so maybe not a better option there.
Generally, no. It kind of reinforces that, especially in the neoadjuvant setting where you need patients to get to surgery. The weekly carbotaxol regimen from CROSS really hits a sweet spot.
Good efficacy and crucially manageable toxicity.
Right. It's considered one of the best tolerated regimens we have for this, which is why it remains so popular and such a solid backbone, even with challenges like ESOPEC emerging.
Makes sense. Okay, we've covered a lot of ground. The core trials, the controversies. Ready to test some knowledge?
So let's do it. Board blitz time.
All right. I'll give you a case. Pause the recording if you need to think, and then we'll break down the answer. Case 1. A 68-year-old man, heavy smoker, gets diagnosed with a T3N1 squamous cell carcinoma of the mid-esophagus. He has severe COPD, deemed medically inoperable. What's the most appropriate treatment? A. Palliative radiation therapy to 30 Gray in 10 fractions. B. Definitive radiation therapy alone to 64 Gray. C. Definitive concurrent chemoradiation to 50.4 Gray. D. Neoadjuvant chemoradiation followed by reassessment for surgery.
Okay. Thinking this through. Locally advanced squamous cell, T3N1. Key point.
Yeah.
Medically inoperable. So, surgery is out. We're in the definitive treatment realm. Based on RTG 8501 for unresectable squamous cell, radiation alone, B, is inferior. Palliative RTA isn't the goal for potentially curative disease. Neoadjuvant D is for resectable patients. That leaves C.
Definitive concurrent chemoradiation to 50.4 Gray.
Exactly. That's the standard of care established by 8501, offering that chance for long-term survival, the 27% at 5 years. Answer is C.
Perfect rationale. Okay, case 2. We're talking about the cross trial now, preoperative chemoradiation versus surgery alone. What was the approximate rate of local regional recurrence in the chemoradiation arm? A, 5%, B, 15%, C, 35%, D, 50%.
Patterns of recurrence from cross as high yield. Okay, I remember surgery alone had a fairly high local regional recurrence rate.
34% in the paper.
All right, 34%.
Yeah.
And the neoadjuvant CCRT significantly reduced that. I think it was down to 14%.
Exactly, 14%.
So rounding that for board purposes, the closest answer is B, 15%.
Spot on. Shows that powerful local control benefit of adding the neoadjuvant radiation. Answer is B. All right, case 3. A 55-year-old woman, healthy, diagnosed with a T3N1 adenocarcinoma of the distal esophagus. She is medically fit and a candidate for esophagectomy. Which of these options is not a standard treatment for her disease? A. Definitive chemoradiotherapy to 50.4 Gray without surgery. B. Preoperative chemoradiotherapy to 41.4 Gray followed by surgery. C. Pre- and postoperative chemotherapy with surgery and no radiation. D, surgery, followed by postoperative chemoradiotherapy to 45 gray.
Okay, fit patient, resectable T3N1 adenocarcinoma. We're looking for the option that is not standard. Option B is the cross regimen, definitely standard. Option C is perioperative chemo like FLOT or MAGIC, definitely standard. Option D, postoperative CCRT, has some historical basis from INT0111C, maybe less used now, but still considered a potential option in some settings, like if margins are positive after upfront surgery. Option A, definitive CCRT without surgery.
For a fit, resectable patient.
That's the one. Definitive CCRT is primarily for unresectable or inoperable patients. If they're fit and resectable, surgery is a key part of the curative plan. So A is not standard for this patient.
Excellent. Answer is A.
Okay, last one. Case 4, what is the approximate pathologic complete response rate for a squamous cell carcinoma of the esophagus following neoadjuvant chemoradiation based on the CAROPHYS trial? A, 10%, B, 30%, C, 50%, D, 70%.
The key here is squamous cell in CR.
Right. We talked about this. Adeno was 23%. Squamous was much higher.
Squamous smashes PCR.
Squamous smashes PCR. It was 49%.
Which rounds beautifully to
C, 50%.
Perfect. That histologic difference is crucial. Answer is C. Nicely done.
Good review. These cases really help solidify the principles from the trials.
Absolutely. So let's just quickly summarize the big picture from today. We really focused on the two absolute cornerstone trials for esophageal chemoradiation.
RTOG 8501 for the unresectable setting.
Establishing definitive CCRT with that incredible survival benefit, 0 to 27%.
And the CAROPHYS trial for the resectable setting.
Establishing neoadjuvant CCRT with the well-tolerated weekly carbotaxol and 41.4 GI regimen, improving R0 rates and survival.
So, the key takeaways. Unresectable disease. Definitive CCRT to 50 gray per 8501 is the standard.
Resectable disease. Neoadjuvant therapy is the standard. The cross protocol is a proven, effective, well-tolerated option.
But we also touched on how things are evolving.
Right. Trials like Esophagus suggest maybe perioperative FLOT chemotherapy is better for adenocarcinoma?
Though the comparison is complicated by the lack of adjuvant immunotherapy in that trial's cross-arm.
The bottom line, as always.
You have to tailor the treatment. Consider the histology adeno versus squamous. Consider resectability. Consider the patient's overall fitness. It's a multidisciplinary decision, always.
Excellent summary. We really hope this focus session has helped clarify these critical approaches to esophageal cancer.
Yeah, absolutely. And keep building on this. You can find practice oral board cases and more resources over at radoncsmartlearn.com. That's radoncsmartlearn.com. And make sure you subscribe to Radonc Smart Review for our next session.
Speaking of which, in our next session, Esophagus Part 3, we are going to tackle two more really important topics. First, the whole debate around radiation dose escalation, should we go higher than 50 grays for definitive treatment?
A long-standing controversy with some key trials to discuss.
And second, we'll dive into the modern era of adjuvant immunotherapy with Checkmate 577. How is that changing care after surgery for these patients?
Huge topic. Really changing postoperative management. Definitely want to tune in for that.
Absolutely, don't miss it.
Thanks for joining us today.